Together, we can.
Together we can.
Together we can.
Together we can save lives. Please give to our research projects. Visit kidneycancercanada.ca.
Interesting. So we're going to be talking about Survive It. I do wish to give a little warning. We're going to be talking about palliative care in this section. And when I first heard the word palliative, it made me freak because I was lying on the gurney just about to go in and have my kidney out, and I said to my urologist, "Is this palliative what we're doing?" And he took a beat and said, "Possibly." And I went, "Oh, okay." But I learned that palliative really doesn't mean it's end-of-life care, and I think we're going to talk a bit about today. And it can be a difficult topic to hear, it can be a difficult topic to discuss, but we wanted to do it because it is part of care. And I think you're going to hear something from Laurelea today, is that do it sooner than later. It doesn't mean end-of-life care. We have to get rid of that myth that that's what it is. So joining us on the panel is Dr. Dugald Seeley. He is a naturopathic doctor. And also on the panel we have Elise Andreoli. Oh, and she's a caregiver and volunteer. And to moderate this panel, I was going to moderate with her, but I'm going to sit in the chair now. She's just discovered that. And is Laurelea. And Laurelea has experience as a caregiver and is quite passionate about some of the topics that we're going to be discussing in this section. So I hope you will jump in and ask questions, even though it may prove to be a difficult question for you. I think you'll be happy with the answers. Let's welcome Laurelea.
Thanks very much, Stephen. Just to start, a little bit of a story. So when my husband was diagnosed, a friend of mine whose husband had also been through the cancer journey said to me, "Laurelea, really important. You need to know that you should ask for a palliative consult as soon as you can, because it can be incredibly helpful to deal with possible side effects, the whole psychological thing that you go through in cancer, and it can just be a really good thing, because palliative doesn't mean the last few days. It means how do you cloak the journey with some comfort about the different things that can affect you, from physical to mental to emotional." And I had no idea about that, much like you. I was like, "Are you kidding?" Anyway, when I bright-eyed and bushy-tailed, I'm with the oncologist and my husband, and it's like meeting number 2, and I said, "And do you think we could get an appointment with palliative? I understand it's a good thing to get in early." And he dismissed me right off the mat. He says, "Oh, we're not there yet." Well, so here's the thing. Actually, in his case, he was right off the bat terminal and palliative. That was the nature of his cancer. That's what it said on the form when we got it in the mail for his insurance. But it took 10 months before I was successful in advocating for him to get some supportive care and the experts in the palliative area. So, and then by then it was too late. So I do have a message that it is a really good thing to get early people who are looking at the whole of you, and not just the whole of you, the patient, but at the family. And that other person who's in the room at all those meetings, but sometimes can feel like they're invisible, namely the caregiver. And I know there's a number of caregivers here today, and that you are the one who knows most intimately every inch and part of that person who you love, who is going through this directly. And it's wonderful when you do get great palliative where they really are concerned about the whole family and helping to cloak or make easier your life so that you have as good a life you can to the last breath. So that's why I'm passionate about this subject.
You say live it to your last breath, but when you hear the word palliative, Do you go through shock? Are you in a grief situation there? Because some people would say, if I go to palliative, it's an acknowledgement that I'm going to die.
You know, I'm sure that Dr. Seeley, that you can speak to this too. There are so many things that you go through in this. And someone said, I hate the word journey. It's more a Poseidon adventure. You know, there's just tremendous drama. Are some of you, had you had those drama days and experiences from the deepest part of your being where you are in like that shock or that awe or that low or that depression that comes? I mean, I was just looking, 20 to 60% of all patients with a cancer diagnosis, advanced cancer diagnosis, experience depression. Mood is huge when it comes to quality of life. But sometimes the focus is on how big's that tumor, what's going on with those side effects. But the side effect of the spirit sometimes gets missed unless you have somebody who is part of your healthcare team that is being responsive and inquisitive and curious to know how you're doing there.
You know, it's interesting, when I was diagnosed, going through, and I mean this sincerely, I don't know if I'd still be here today if it wasn't for my husband, because there were times when we'd be listening to what a clinician was saying to us, and I'd come out and I'd say, well, they didn't tell us that. And he would tell me, well, yes, they did. Don't you remember? 1, 2, 3. And the other thing that I found as a caregiver, maybe get you to jump in on this, is that they really do advocate for you, and help you to see through the cloud of the shock and the treatments. Is that a reasonable comment?
I totally agree. Sorry. I see patients in my office. From what I perceive is that patients, they feel so down. My role is to accompany you in your journey. You know, I just would like to explain the word palliative care. As we said earlier, we tell you, you're in the palliative care, you have a palliative illness, and people right away think it's death. But don't forget that in oncology, there are 3 phases. The first one, which is the curative part, meaning that you can heal, you could get over your illness. As soon as you have the nephrectomy, you have a follow-up, and after 5 years, there's no recurrence, you're healed. In the palliative phase, it's when there's still illness there. That's a palliative phase, meaning that you can no longer heal it. We're starting treatments for some others will be observed. When I tell people you're in palliative care, you're not at the end of your life, meaning that you're stabilizing the illness and you're trying to, push away the last phase. As a oncology nurse case navigator, I'm telling you to accept help from the outside. I often refer my patients. I work at the CHUM in Montreal. On the island of Montreal and around, we have palliative resources that are there to accompany you in that journey. We have resources of people who come to your home. We have nurses, social workers, psychologists. As a nurse at the hospital, I coordinate things. I help you to understand the network. But also, if you have closer people who are closer to you, they talk to us too. And when we treat a patient, we also treat the family. My role is with the family. We try to understand. We try to we try to help you to move forward, because when you learn you have a diagnosis, there's a transition. How will you be managing situations in your life? And knowing this, it will help me to accompany you in your transition to make sure that you're perfectly independent or to become who you are in a new life situation. So that is my role. And I wanted you to know that it's important. It shouldn't scare you when doctors talk to you about palliative stage, and it allows you to have resources. Even with the side effects of the treatments and of the illness, the professionals have a role to play. But because I'm close to the patients, as I said earlier to Madame Veilleux, I think you are very inspiring in what you're going through and you're fighting. So what I like is to accompany those people to manage the side effects. We talked about diarrhea. I have patients who focus on diarrhea and they could no longer live. By accompanying them, by changing the way they eat, with other professionals, we all work all together and have many patients who say, wow, we can live now without too many side effects. Those side effects, well, no, they don't paralyze us, but they stop us from having a full life.
I think it's really interesting having the discussion of, I guess, complementary and naturopathic medicine in the context of palliative care. And I think a lot of what we do and what patients are seeking from complementary medicine practitioners is palliative care in the true sense of helping to reduce some of the symptoms that they're dealing with and help them to manage and improve quality of life. The focus on the disease and the pathology is so effective at the hospital in so many ways, but often I think patients don't have the time necessarily to discuss some of the issues that they're dealing with related to digestive complaints, anxiety, you name it, that are really impacting their day-to-day life. So a lot of the support that we offer at the center and other, I would say, complementary practitioners and naturopathic doctors are focusing on those key areas of supportive care. And I think to do that in a way that's safe, isn't going to cause interactions with medications, all of those things have to be considered in the whole discussion. So I'm delighted that this is part of the panel and the discussion and that we've been invited to speak. My father was a palliative care physician and a nephrologist too, so it's funny. I think I feel like he's right with us here with me, anyways. Now, in terms of the context of this, but there's people want support. They want questions. We don't always have the right answers. Often it's working with the person as far as what they're willing to do and what they want to do and what resonates for them. So in some cases, that's going to be food and nutrition, and that really works because we're almost empowering patients to make choices for themselves that feels right and does resonate. Or it could be acupuncture, which can be tremendously effective in many cases. It can be used of certain supplements if it's done in a safe way and isn't going to interfere with the medications. And really, I think there's a lot of different places where people will come to see complementary medicine. And as it was described before by Dr. Flower, the discussion with the physician, with the oncologist, well, what's happening, I think needs to happen more. So there's a bit of a breakdown of some of the barriers that do exist. Time is a big issue in that, though.
The trouble is, my experience has been, doing, I'm doing acupuncture. And I'm like, yeah, and I think it's helping. Well, there's no evidence that it doesn't, and if it's not hurting you, just go ahead and do it. It's like there's this almost disbelief in complementary medicine. We talked about this with Dr. Flower earlier, that I say, hey, I'm living proof that something's working. How do you overcome that attitude? Because, you say work as a cohesive team, but some docs just don't want to go there.
Yeah, and I think in some ways it's unfair perhaps to ask the physician about things that they may not necessarily have the training in, which is complementary medicine. I think it's fair to ask, what are the kinds of things that I should be asking a practitioner, not whether I should do it necessarily, but what are the things to worry or to be concerned about? A, what's the cost of the therapy? Are there any potential for side effects? Are there interactions? Like, those are the questions that people should be looking at, especially where there's so much information on the web and misinformation that's available around complementary therapies. People come to it for various reasons. So I think opening the discussion, but not necessarily expecting our physicians to have the answers about what's right or wrong, but allowing the questions to unfold as to what should be asked.
We do have some questions in the audience. The one thing that I'll just put on the table right now, I was hosting a radio program when they were talking about making changes to medical marijuana and some other legislation. And Ted Smith, who's an advocate in British Columbia, comes on my program and says, well, I mean, they should legalize it because it cures cancer. And I said, you have no right to say that on the air. Nope, cures cancer. Medical marijuana cures cancer. And I bet you there's not a person in this room that hasn't Googled and gone on and looked at this. And there are claims that this is the be-all and end-all of treatment. That you only need to give yourself over to the what was that terrible documentary they did on medical marijuana? Huh?
The Truth About Cancer?
No, it's the one about the evils of marijuana. They did one years ago, that it would drive you psychotic and all that. How do you respond to that? Because the thing that I found is when I first diagnosed, tons of people come to you with tons of solutions on how you're going to be cured that are not in Western medicine.
Yeah, we talk about this all the time. We just had a group discussion at the center just about this issue in particular. How do we provide our expert guidance, if you will, on our knowledge around certain complementary medicines without disparaging perhaps what the patient's coming in with and what their belief system is. So I think we take a rational prescribing approach where you look at the potential for harm associated with what they may be doing. If there is low potential for harm for it, and they feel like it's helpful, and we don't have evidence for it, we're not going to discredit it necessarily. But if someone's coming in with something that they're doing that could potentially cause harm, then we're going to talk about that and hopefully steer them away from it or provide other options that are safer, have more evidence for use, and are more feasible for application. The medical marijuana issue is a huge one we deal with all the time. There's 3 questions that we were just talking about around for lunch. I think it can be supportive for symptom management at this point, for appetite stimulant, for fatigue, and not fatigue, for insomnia, and for pain. But as an anti-cancer therapy, there's very little evidence to support it at this point. There's some interesting, but it's really preclinical, and that's all it is.
So what are some questions that you have for the panel? We must have sparked some thoughts out there.
Well, I guess my comment was more just to the question that was asked before about the resistance and the difficult barrier of bringing in complementary medicine with traditional Western medicine. And, you know, I think part of that is for us to understand why is there resistance. And so if we begin to understand why oncologists or healthcare teams are not prescribing or not referring to centers that offer complementary services, maybe it's because they just don't know or they don't feel comfortable in that. And so we did a study to actually look at the resistance as to why are physicians not prescribing physical activity for their patients. And amongst the 150 physicians that we surveyed, lack of knowledge of the benefits or the belief that it will actually do something for their patients, or they didn't receive training. And so in 2017, there's been action to actually incorporate training of any new physician going through residency on physical activity. And so that has taken a number of years to get into place, but basically the new generation of physicians that are going to be coming through are going to be trained on prescribing physical activity in the general setting, but also in oncology. And I think that at some point in time, if we get more evidence on other modes of complementary therapies, we can then incorporate them in the curriculum, either during the program or as continued education, not necessarily to make them experts and them become the specialists, but at least understand why they should be referring if their patients present certain symptoms.
You know, it's interesting, in the patient survey that University Health Network did for Kidney Cancer Canada, when you look at where people are getting their information from, and Deb, I'm struggling because I remember doctors, GPs was low on the list. It was down about maybe 30% or something. It was really low. And out of the people that went to see their doctor, 1 in 4 felt that they had received reasonable information. So I guess the challenge, then, I would say, is are we educating the medical community, as you pointed out, or are we going to the wrong source?
Yeah, I think that, I mean, medical doctors would be a much better place to respond to some of this, but I know the education for integrative medicine, there is actually a module in second year, so there's an attempt to incorporate consideration for what integrative and complementary medicine is and the realm of it. It's such a huge, broad field. The CAM umbrella of complementary and alternative medicine ranges from prayer to, you know, very, very complex, difficult, energetic methods that's very hard to replicate. So it's a massive spectrum, and you've got all kinds of different practitioners that are regulated for it. So I think relying to some degree on the regulatory bodies, and in a province we have some good regulations for different types of complementary medicines, which is good. That's helpful. So knowing who to refer to and when is appropriate, and again to address the right questions. But I don't know if any of the physicians in the audience want to address some of the barriers or not. But
they will in a minute.
Do we have a question?
Hello? Okay, it's working. First, I'd like to comment to Stephen. I was just going to ask Laurelea a question, but you mentioned about the lack of communication between specialists, doctors, family physicians, so on. That is always an ongoing difficulty that we have found with Kidney Cancer Canada, and I'm sure all you patients, you know, one is doing one thing, your doctor says another thing, and there's the lack of communication in between, and we are always advocating for different ways and that we can solve that problem. It's a difficult problem. I'm glad that you brought up the spiritual aspect. You mentioned very briefly prayer, and that it's the whole body. When you are diagnosed with cancer, mind, body, soul, you need to address all. And maybe you haven't been a soulful person before your diagnosis, but often you find there's a big change after your diagnosis. And finding that resource is important. And my question to Laurelea is the resource, if you're considering palliative care or the preparation for palliative care, where do you recommend that we go? Where can we find that right person? Because not all palliative care is the same.
No, that's true.
And so we want to make sure that we're on the right track. Do you have any recommendations on where we might find that resource?
Well, here's my experience at, for example, Sunnybrook. I had no idea, and I'm sure it's the same in other cancer centers, that they do have patient and family support, which includes the ability to refer through direct to palliative, nutrition, social workers. In our case, after 10 months, we managed to get into patient and family, and a doctor there whose sole purpose as part of the patient family support was to engage in conversations with families and individual patients around how they're doing and what they're seeing going forward and what questions or concerns they have, what fears, what anxieties. And so I didn't realize that there was a whole group of professionals who were there purposefully to support the bigger picture beyond the specifics of the disease. So I would encourage people to investigate whether their cancer center or healthcare group have such a part. I will also say that, you know, we talk about complementary care and we've talked about palliative. There's a big barrier in that I'm working hard at Sunnybrook on their Quality Living and Dying initiative to educate the oncologists and the specialists about the benefits of early palliative referrals, because they haven't really learned that. It's been a long time since they took their class in palliative. Their specialty is how do we nip this sucker in the bud, and what do we do to buy more time and treat, and really focused on trying to extend a person's life. And there are many wonderful scientists who choose this because they are passionate about finding cures and finding ways. But there's all this other professional that they maybe don't get because they see it as soft or fluffy, and it's really integral to supporting the individual and their families. And also, I just want to share this. When I was invited to go around to the different clinics in the cancer center and sort of share my story, along with the patient and family support team that was trying to raise awareness that they needed to encourage their patients and their families to seek out these supportive services. And here's something really interesting. A doctor said, well, how can the caregiver, how do they get in the system to get support from a doctor and patient family? And it was just a simple answer was there's a number, you put that number down and the caregiver becomes a patient who can have that supportive care. And I just want, 36% of all men who are caregivers of somebody with advancing cancer suffer from depression. That is a statistic, and 14% of women. So we have these walking sufferers who sometimes are not, but the hospitals can be, cancer centers can be set up to help. And that's a really good thing. Are there any other questions?
Over here.
I just wanted to make I was at a GU cancer conference with physicians from across Canada and patients as well, and we did roundtable discussions about various things. And one of the things, I also work for medical software, so I deal with physicians at work as well. But one of the things that was shocking to everybody, one of the physicians said that he would not hand out a Kidney Cancer Canada flyer, to which everybody jumped all over him about. And his response was, if I hand out that flyer, it opens up conversation, and I have 7 minutes to deliver medical information, get that patient referred on. So at the same time, I don't think education is only part of it. If we teach the physicians about diet, they all know diet and exercise is fantastic. They all know about some of the palliative care services. There's multiple services, and all patients, regardless of stage and whatever, should all have access. But for a physician to give you all of that information when they've got, I mean, who sits in the waiting room for an hour? All of us do. It's because we're all jammed in for a limited appointment to get what they have to get across to us in 7 minutes. Some physicians are better than others and just take the extra time. But truthfully, if we want patients to be referred to the best and to get into the best, they have to be in and out the door. So you have to be your own advocate. Not everybody has a great oncologist or a great GP. I personally have fantastic services, but you have to advocate for yourself, and you have to jump on the bandwagon and read the information. Kidney Cancer Canada is a wealth of information. Mm-hmm. Deb was my wealth of information when I started 9 years ago, but you have to look into what's beneficial for you and request that information. I really don't think you can put it onto the GP or the oncologist to go over all of those services and everything in the 7.5 minutes. I mean, they're all double booked for 15 minutes, so it's 7.5 minutes they have to discuss results and everything with you.
But where do you think, I mean, I advocate in Calgary that, a diagnosis of kidney cancer, in any level, really the standard of care should be a referral to Kidney Cancer Canada, the only patient support group. Because, I mean, surely Kidney Cancer Canada, and this is really, we've talked about this time and time again, can pick up a lot. And I know, is Neil going to respond in a minute? He's got a mic. Let's get Neil to respond first.
I had a question first.
Is that it can take a load off of that 7-minute interaction. You know, because you're sitting there. I mean, in my case, hey, you've got a 9.5 centimeter tumor in your kidney. Well, what are we going to do? And I remember, so, well, you take it out. And I swear to you, I said, what, the tumor? And the doctor went, no, the kidney. And, then the next thing is you have all these questions just flying through your head, which I'm sure that a doctor doesn't have the time to answer. So where do they go? Mm-hmm. Maybe that needs to be part of the process. I'm not advocating that it's solely Kidney Cancer Canada, maybe Neil, but something has to happen.
Well, let's have Deb ask her question or comment.
So I'm going to entirely endorse that physicians should contact Kidney Cancer Canada for patients to call. So I'm going to make my comments with stating my bias right up front. So all of us have inherent biases in our beliefs. And my bias is heavily in the camp of evidence-based medicine. I'm a research advocate in Canada, the US, and internationally. So I rely very heavily on where we have evidence. And where we have evidence for interventions that work, I will lay down my life and fight for them to get kidney cancer patients access to them. So that's my preamble. So be careful of what's going to come next. So I speak to hundreds, over the last 10 years, I've spoken to hundreds, maybe 1,000 patients. And many, many patients ask me, Deb, what do you do? What keeps you alive? So I'm going to tell you my secret right now of what keeps me alive. I drink Pinot Noir in heavy quantities. Okay, but that is not evidence. That is anecdote. And the danger of you drinking a bottle of Pinot Noir every day and following that advice is there is no evidence that Pinot Noir affects kidney cancer cells in their growth. It does affect your quality of life. And I would personally advocate it. There's not a chance we're going to get that reimbursed, I can tell you. So what I'm really worried about is when we talk about complementary medicine, I'm absolutely all for activity, exercise, spiritual care, and support. And we all need all of that. But so many patients will say to me, what do you think about vitamin C? What do you think about this? What do you think about that? So what I generally say as a peer support person is you need to do whatever you feel comfortable with. I'm not here to tell you. Be careful of the anecdote. Be careful of the single patient online who said, I've done cannabis oil and I'm cured. And another patient is doing magic mushrooms and they're cured. Because these are all rat's nests and we are so vulnerable as patients with terminal disease. We're so vulnerable to these anecdotes. So I'd be very careful about following any individual's advice and anybody who has a motivation. So if they have a clinic, if they're selling supplements, if they call themselves a nutritionist, because they may not be a registered dietitian. So I think we have to have our guard up. And for Kidney Cancer Canada, my belief is we advocate, and we've always advocated for evidence-based medicine. So please show us what works in kidney cancer, not other cancers, because we're really focused. What has effect on renal cell carcinoma? Give us the data, and then we'll help to get that word out. But if as an organization we start to advocate for things where there is no evidence, then personally I feel that we lose our credibility. That's the end of the rant.
Okay.
I just wanted to totally agree with your statement about anecdote and how it can lead people down very difficult paths. And I think we need to develop evidence that is based on low risk of bias, randomized trials that look at these things. And I would also pitch for the possibility of more research into some of the non-pharmaceutical medicines that don't have perhaps some of the funding behind it. So we're lucky we have some foundation support for funding this type of research. There is a lot of, I would say, low-lying, promising potential therapies that don't get the attention and the research they deserve because there's no monetization. And that's not to say the pharma industry is evil or anything like that at all. They've phenomenal achievements, but we need to be looking at other therapies and how do we fund that as a challenge. But the anecdote, totally, I wholeheartedly agree with it.
I think the number one cure right now is on Facebook. It's to cut and paste this message. It will save lives. And every time I see it, I'm being facetious, of course, but or people send me the message on Facebook, please do this, Stephen, if you listen and want to support someone with cancer. And I cringe. It takes me every ounce of my body not to write, do you know how really effing stupid this is? And insulting to a cancer patient. People would come up to me and say, when I was diagnosed, can I pray for you? And I'd say, absolutely. Do you believe in prayer? I said, any positive thoughts that come in my way, I'll take them. That's the view. But I don't know. There's my rant about Facebook. It just drives me nuts. Neil.
Sorry. So yes, I guess I was supposed to comment back on the discussion around groups in silos and so forth, and physicians' willingness to refer, whether it's Kidney Cancer Canada or to other disciplines and stuff. And I feel for the physician who has the 7 minutes. That is unfortunately the reality of our system. And every center has its own battles. Like our psychosocial oncology group got gutted by the hospital and money given somewhere else. So we're really lacking on that availability to us. But I think that it all comes down to communication. Setting up community, even within our center. Luke and I work. We have a great group of uro-oncologists, but just even the physical 7 floors between us could be, across the city sometimes, and it's always a challenge. So I think any way that groups can communicate their goals and objectives and individual patient information will facilitate that. So Dugald's, Dr. Seeley's clinic across the way, we're still probably in the infancy of working together. The clinic's been open for a while now. We have plenty of patients that we share back and forth.
How do we break those barriers, Neil? How can we get, we were talking about this in Poland, how can we get, even communicating, for instance, with urologists, and I do apologize if there's urologists watching this online later, reaching them to talk to them and give them material that really could help them, help their patients. It's very, very tough.
Yeah, no, I completely agree. I don't have the solution to that, but it's always an ongoing process. So I think that when physicians in whatever scenario seem a little hesitant, it's probably just because of a lack of communication or knowledge. And I think that it's a constant, it's a work in progress. And I think Kidney Cancer Canada has done a tremendous job. One of the best communication strategies I've seen of any of the groups. Other people are trying to emulate it, but they're playing catch up on you guys. So kudos.
What do you think?
A lot of your docs, and I know this is the carrot and stick approach. Run clinical trials and get money for research and that. I'm wondering if some of the criteria really should be, even for the money that Kidney Cancer Canada puts into the research network, if we should be saying one of the criteria is for your application is, do you work in an integrated environment? Because no, Deb's shaking her head.
I don't agree with that.
Well, I disagree. That's why we have opinions, right?
Well, I guess one of the pieces is how are you going to translate the knowledge you're going to generate from that research money?
I'm not saying that I guess what I'm saying is, surely if we are better, stronger together than we are working in silos?
I think what's really exciting and positive that's happening is that we are having more collaboration and more awareness building of the value of coming into a more integrated approach to dealing with these things than we have in the past. And even when you look at, I used to work in the PR business, and back in 1992, I said, I think that we should go after the supplement business. Like, find something small and try and make it bigger in terms of, seeing alternative supplements in drugstores, for instance, because you might find vitamin C, that was it, in a Shoppers Drug Mart. And you go into Shoppers Drug Mart today, you've got a whole wall, right? That has happened in the last 25 years. And there is more respect being given to non-Western, thousands of years experience with certain things. And Deb, I agree with you around evidence, but I also appreciate that there's difficulty with funding to do that kind of same research for these things that don't have big corporations behind them. But I think what's really hopeful is that minds are being broadened a bit when it comes to palliative. You used to never want to say that word. You used to never want to talk about how do we live our lives till the end? Like, don't open that door. And now people are bringing it up. It's doors and windows are opening to conversations about all of life, which does include death. And that's a good thing. And that's fairly recent in our Western world. And so I'm encouraged myself by I look back at when my husband was here. These things weren't even talked about then. So that's 3 years since he's been gone. So I think it's a very encouraging trend that we're on for patients and their families.
Thank you. I'm going to change direction just for a minute. I'd like to speak to the oncological nurse. How do you offer? I know you probably have specific duties for your patients, but does it come up in conversation, other directions such as palliative or nutrition or exercise? Is that something that you deal with as you guide your patients through?
Yes, it's part of my work. When I speak to my patients, I use the guide that Kidney Cancer Canada wrote, and I look at that guide with the patient. I explain to them the importance of moving to continue to receive the treatment. I think the fact of moving, of finding fresh ideas, to finding an appetite for life again means that patients respect their treatment better, and we can receive treatment over a longer period of time. Because as we were saying before, the whole spiritual and psychological aspects are as important as the physical level. If at the physical or at the spiritual rather or mental level I have problems, it'll have effects on the physical side. So say the patient is really tired because the patient isn't moving, is not sleeping, is not going out. If the patient doesn't move well, the patient won't be hungry. There's no energy being spent. And if the patient doesn't go out and always stays at home, well, the quality of life decreases, and it becomes a vicious circle that leads to depression. The human being is a whole. It's not just a kidney, a pain, a hand and foot syndrome. Patients who come to me with big hand and foot syndrome, I don't just treat that. I look at the entire patient. I had somebody come to me that was that had a grade 2 or 3 syndrome. I want to see what they do as work. They're analyst programmers. They're always working at their computer keyboard. Well, they have a bigger risk of developing hand and foot syndrome. Or patients who have metastases, they move with crutches or something else. They have stage 3 hand syndrome. Well, that's pressure that happens when they're moving. So I take all of this into account. When I have a problem at the food level and I can't manage the symptom, I'll go discuss with the nutritionist. And yes, it's difficult to talk about this, but I do talk to my patients about palliative care. Often that goes through me. The patient often has difficulty speaking to the doctor about it because there's not a lot of time to speak with the doctor. So when the patient comes to me, sometimes I'll take an hour with my patient. And so they talk to me about their fears and anxieties. And often I'll ask them, did you think to ask the doctor to have a consultation at palliative care just to treat your symptoms? And the patient will say, no. And then I explain what the role of palliative care is. And sometimes I go speak to the doctor and I'll say, Dr. So-and-so, I think this patient might benefit from immediately having a referral to palliative care. We can maybe be better able to deal with second side effects because we'll have exhausted our gravel and other possibilities. So everything's better when you work as a team. When you're working for a team, it's not a question of saying, well, we're choosing a good doctor. You have to choose a good team. So I'd like to acknowledge the role of the Oncology Nurse Care Navigator, because I spend 15 minutes with the doctors every 3 weeks, but every week I have a nurse care navigator and I tell her, well, I have pain here, what can I do? So the information is often communicated to me by my nurse care navigator. So, as you're saying, if we use those resources, it's good.
I don't know. I am from Quebec, and we have this pivot nurse system. So, I recognize that most of the information comes from the nurses to me, more than the doctor. Of course, gives the prescription, discuss the results, etc. But the day-to-day surviving it's with the nurse. So, that would be a more. Maybe if you want to disseminate information about naturopathic thing, I personally don't believe because I am more evidence-based thinking. But if there is some things to be done, maybe the nurses should be trained also on that.
So we spend much more time in the office with the patients when we're nurses. So when we come out of the office, we're there to demystify things. Well, sometimes it's the patient and sometimes their spouse or their caregivers there. Sometimes the doctor doesn't use language that the patients are able to understand. So our role is to express that in terms that the patient can understand.
I just wanted to comment because I was involved in a big forum in Montreal a number of years back, and Quebec is unique in having the nurse navigator role, quite unique. It's not a standard in provinces across Canada. Also, we need to be looking evidence-based, and we need to be looking at care paths. Patients have a care path. It should be built into the care path that if the physician only has 7 minutes, somebody else has got the hour that they can address these issues. Because I'm counseling patients on the phone, and the number one thing they say is that they couldn't, the information that Kidney Cancer Canada eventually gave them, they wish they'd had up front. They wish it had been part of the care path. And I'm so happy. I think Kidney Cancer Canada has been successful because it has a medical advisory board, and everything goes through that board. So it has an evidence to it in that sense of what type of information you're handing out. And so if we could organize a system that said, and this is real large system, healthcare doesn't keep cutting back. I was sad to hear Neil say that the supportive care services are getting cut back where he is because Ottawa had some of the greatest supportive care services in the past. And we can't let these services disappear from our healthcare systems. We have to advocate that they be there, and that organizations that are credible, like Kidney Cancer Canada, will be tagged in as the go-to place that patients want to talk to another patient, because that's another thing that patients really want to do, is talk to someone who's lived the experience. They don't want to talk to someone who hasn't had kidney cancer. They want to talk to someone who's had kidney cancer because they know that person understands. But they also need the nurse navigator and the physician and the whole team, like you say, to do all the other pieces. It's a puzzle that our healthcare system has not put together very well, but it has come together in cancer a little more neatly in Quebec.
We have about 30 seconds or so left, I think. So we want to wrap it up. I mean, one thing that hasn't come up today that I would like to put on the table, and Deb's heard me say this many times, and many other people as well, is that I believe in second opinions. And I say again and again, second opinions save my life. And I think they do save lives. And I think all of the peer support team here at Kidney Cancer Canada that are in the room would acknowledge that once you hear what a patient has to say on the phone, sometimes it can be extremely frustrating because you don't know if the patient has heard the entire conversation when they went in for their first consult. But certainly going in for a second consult sometimes can really change the way that they receive treatment. So we didn't talk about that, but surviving it, I think, does include a second opinion, especially if you're not comfortable with what you've heard. Or if you have doubts about it. And, I know that you would go and get palliative assistance, if you were going through there to deal with pain and that. But certainly if you're not confident in your treatment plan, then you do need to get a second opinion. And the other thing I think is very important in surviving it, getting through for me, and you talked about this, is the fact that I went for counseling quite frequently after the diagnosis. And I remember you talk about depression. I thought I was depressed. And then I found out, nope, you're just grieving. You're going through grief. And I went, oh, grief. I remember coming out of the session that day thinking, tears in my eyes. My eyes were red. I had this moment that it was an extreme relief that I wasn't depressed, that really I was just going through this normal process of grieving, and that helped immensely. Yeah. And I think as guys, we need to step up and admit we need help. Sometimes we don't. We pretend we can carry it, we can handle it. We are the stable horse in the relationship, and we are going to put everything in order and make sure that should something happen to us, our life is going to be okay. And that the lives of our loved ones is going to be okay. Yet, at the end of the day, your caregiver is sitting there going, talk to me. I need to know what's going through your head. Because if you don't share it with me, if you don't share those details, if you hide little details about how you're feeling or what you know, and your fears, it becomes a very lonely journey.
Stephen, if I could just add on to that, beautiful segue, because often we don't want to burden our loved one. We're afraid that if we share our struggles and our fears, that we'll be putting more burden on them. And I think that, yes, absolutely, the importance is to have those conversations, because there's BC before cancer and there's the world of AC. You cross a line where you come close to thinking, oh my God, I'm not going to live forever, maybe. and your loved one comes to that same place too, and the communication is so important. And that's why I wear this sticker. I love ACP, and ACP is called Advanced Care Planning. And Advanced Care Planning is having the conversation with the person who, if you cannot at some point speak for yourself, will need to do the speaking for you, and to have the conversation about what matters most to you, what you value, what gives meaning to your life, what you're prepared to trade off in order to have more of that thing that gives you joy. Those conversations, not just about where the financial affairs are in order and where the insurance is and the many passwords for the accounts should something happen, but no, something that will help them evaluate on your behalf directions from the medical professionals on what options might be there to treat you or to care for symptoms. And I did this with my daughter after Steve died, and so that she would not go through the agony I went through of not knowing exactly what Steve wanted, because we didn't have those conversations. So if you get a chance, and we have the village still going, hope you'll come and pick up a piece that we've done at Sunnybrook to try and support people in starting those good conversations so that you live the best life to your last breath.
Thank you, Laurelea. Thank you, Dugald. Appreciate it. Thank you, Elise. Well, first of all, we should acknowledge our panelists for joining us. Thank you so much.